Welcome to this BTOG podcast. My name is Tom Newsom Davis and I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm Vice Chair of the BTOG Steering Committee. I hope by now that you know that this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their field and we tackle the most important questions that we all face in the diagnosis and the treatment of thoracic cancers. It's important to say that the sponsors of BTOG do not in any way have any input to the planning, content, or delivery of anything that we discuss. So today's podcast is called BTOG Does What's New in Lung Cancer Nursing. I'm absolutely delighted to be joined by a friend of BTOG, member of the BTOG Steering Committee, Karen Clayton. Karen is a lung cancer specialist nurse, of course. She is a lead nurse at East Cheshire Hospitals, and she's also the Vice Chair of the Lung Cancer Nurses UK group. So she is a busy lady. Karen, welcome to our podcast.
Thank you, Tom, and thanks very much for the invitation.
It's our great pleasure. So we, by complete coincidence, or pretend it was deliberate, but by complete coincidence, we have chosen this meeting about 5 or 6 days after the first inaugural National Cancer CNS's Day. So it's a good time to be discussing all things cancer CNS. Tell me, Karen, with the National Day, what was that, do you think, trying to do? Because the impression that I got after our chat before this podcast is maybe we don't understand the role of the CNS that well. What do you think the role is and how can the Lung Day improve that?
I think it's been a really important national campaign to try and improve the understanding of what a clinical nurse specialist does. I think if you're working within the role, it's quite evident, but if you're not in that arena, it can be quite mystifying to what we actually do. I mean, the role, it's a very complex role. We do all sorts of complex care, working alongside our colleagues to make sure that the patient has the best outcome, best experience that they possibly can. And that can be from physical symptom control, emotional and psychological support. So it's a whole package that we provide. And I think sometimes our colleagues don't really understand that. So today was to try and raise the profile.
I think people don't understand it, actually. I think we should by now. But I guess what we perhaps want to focus more on is what's new, because there are lots of things going on, and how is the lung cancer specialist nurse role evolving? What challenges do we have? And my understanding is that Lung Cancer Nurses UK have produced a report which is really focused on this. I wonder if you could tell us why that occurred, or maybe what your salient findings were.
Yeah, of course. So obviously, over the past 2 years, it's been extremely challenging for any healthcare professional. And in the beginning, CNSs were redeployed to the front line, so to speak, which obviously left a great big gap in service. Again, I think some of it was not really understanding the service that we were leaving behind. And we wanted to produce a report that would help our lung CNSs to really shout about what they do to the wider audience, and hopefully not be redeployed again.
Yeah, I mean, it certainly had a huge impact, hasn't it? And I think our nurses are now back in the fold, but it was a bleak time. And is it, apart from that kind of preventing the redeployments, I think you also mentioned in our pre-podcast chat about other things like retention and how do we attract new nurses? What was your conclusions on that?
So obviously we want to attract new nurses into the profession. You know, we have a lot of nurses that within the next 10 years are looking to retire, myself included. So we need to boost the numbers so that, you know, we can continue to provide the service that we do. So the report, it's the framework, it is complex and caring, was produced for 3 things really. One, to encourage nurses into lung cancer nursing and what they will be expected to, the experience they're expected to have and the qualifications they're expected to have. Second part was to obviously to retain those nurses that we've already got and encourage them into advanced roles. Like you said, the role of the nurses, the lung CNS is expanding. And then thirdly, I suppose, we wanted to produce this for our policymakers, our CCGs, our people, money people, so we can again encourage people into the profession.
Because we do have standards, don't we? And I don't admit I don't know them, but we have standards in terms of the numbers of patients newly diagnosed in a cancer unit per specialist nurse, if you don't mind me putting it that way.
So it's
I can't remember the numbers.
It's 80 per year.
80. Wow.
One whole time equivalent, which doesn't sound, well, it sounds a lot, but that's new diagnosis. That doesn't take into consideration the ones that you'll still be supporting from last year or the year before because of the advances in treatment.
Yeah.
So our caseloads are getting bigger, which is because of advances in treatment, which is absolutely great. But they are getting bigger.
Yes. And I'm wagering that most people listening to this are going to go, one nurse for every 80 patients. We don't have that. And certainly in our hospital, we diagnose around 250 patients a year, and we have 2 nurses. And yeah, it's incredibly busy. And as you say, that the numbers, the activity's gone up because people are living longer, which is fantastic. But that does bring huge challenges, without sounding selfish, with that. Yeah. Okay, when we're thinking about the lung cancer specialist nurse role, is there a standard job description? Is there something that your organisation, Lung Cancer Nurses UK, recommend, or is the job description going to be very variable according to where you are and what you do?
It does, and we're all lung cancer nurses, but we all have a different role within that. It's almost an umbrella term, really, because we'll have nurses supporting patients' diagnostic centres, and then transferring over to oncology, onto tertiary centres, and then seeing patients when they come back, or we'll see patients from pre-diagnosis to end-of-life care, which is what I do. So the job description will be very much tailored to the area that you're in. The framework gives you the idea of what you should be, is the basis of that job description.
Yeah, and is that framework, sorry, my ignorance, is the framework a kind of an NHS national thing, or is that something you guys
are trying to push for at the moment? That's what we're working hard on.
So to have a kind of basic structure, and then you can amend accordingly to your wishes or your interest.
Yeah.
And what would you say to a colleague, let's say there's someone listening to this excitedly on the bus home, and they say, well, this is great because I'm doing job X, but what I really want to do is be involved in, I don't know, the more palliative care aspect of it. What would you say to them? They should presumably go to their line manager and say, draw up and work out their existing plan and then describe what they want? And how would you advise a colleague who's wanting to perhaps shift the focus of their job?
Absolutely. I mean, that's where your personal development plan comes into situ, isn't it? When with your line manager, and you should be developing on how you want to move the service forward. So if you feel that you've got a gap with palliative care, then that's the knowledge that you need to go and gain. If you want to develop a nurse-led clinic, for example, there's lots of resources out there, especially Lung Cancer Nursing UK, to give them a plug, on how to do that, and how to formulate business cases as well.
And they presumably access that through your website? Yes,
absolutely.
There's a plug for you.
Yeah.
So obviously, Lung Cancer Nurses UK, wonderful organisation, almost as wonderful as BTOG.
Of course.
But I think there are other organisations which are kind of in this field, and Macmillan is huge. And my understanding is that they've been very much involved in focusing on nursing generally. You mentioned to me a little bit earlier about a sum they're putting in and their kind of plans for the next few years. Just enlighten us a little bit about that, if you could.
Yeah, so Macmillan Cancer Support did a report on not lung cancer nurses per se, but on cancer nurse specialists and how they're going to be needed in the next few years. And they estimate they're going to need about 170 million to fund around 4,000 additional nurses by 2030 to keep up with demand of patients being diagnosed and needing that support. So it's going to be massive. They said that if they continued with the funding as it is at the moment, by 2030, we will, in England, have a 3,300 shortfall of cancer nurses.
Wow. And yet my understanding is, and I may have misunderstood all the press, but the numbers applying to do nursing are going up generally in the wake of COVID, and people are appreciating this is a much better career than selling houses and other such nonsense. So this should be, we should be on a positive spin, shouldn't we? That more people want to do it, and we have organisations willing to help become specialists.
Yeah, absolutely. And it's about encouraging those new nurses into the specialism. And spending some time with the specialist nurses in the hospitals that you're in, and really finding that niche of what you want to do.
So before we get too overexcited about how wonderful it is, let's focus on the challenges, because it hasn't been an altogether easy couple of years. Don't want to bang on about COVID, but it has had a huge impact on what we do, and challenging times always at NHS somehow. What do you think have been the big challenges generally in lung cancer nursing in the past couple of years, apart from the redeployment, which you've touched on already?
I think supporting the patients in the early time of COVID, where we all moved to telephone calls rather than face-to-face conversations, I think that was quite challenging for a lot of nurses.
I agree.
And we have a lot of patients that are immediately put on the shielding list. That fear factor of having to, support patients through that was very difficult. And getting used to the whole virtual world has been quite a challenge. I think that's quite a challenge for everyone. But you're used to sitting down and talking to someone face to face, picking up those non-verbal cues, and that's extremely difficult over a telephone. Well, you can't do it over a telephone, can you? So, I've got a patient at the moment who will tell you he's absolutely fine, no problems at all, but you go and sit in front of him, and you can immediately say that he's not. So that's been challenging.
Have you found over the years you have to be more accessible? So I was thinking about it at Chelsea Westminster, our specialist nurses now have a mobile phone, which might like a kind of fairly basic thing to do, but it's a comparatively recent arrival the past couple of years, whereas if I look back to when I started here, it seems like a million years ago, it was just a landline. I guess people do rightly want more access to their healthcare professionals in the same way that we all want access more to all of our professionals. So have you found that over the years?
Yeah, and also email. Obviously, we've got a lot of patients that tech savvy, so we're getting a lot of emails as well. Always worry when an email's like 2 or 3 o'clock in the morning, because obviously that patient's up and worrying. So we have a lot of email contact with our patients. Like you say, telephone, patients don't have our mobiles, but obviously health professionals do. And we're also on a bleep system as well. So we are more accessible, I think.
A lot of other roles get pushed on to specialist nurses, sometimes a palliative nurse role, even if the particular specialist nurse isn't wanting to do that role. That's been a perennial issue. I remember that going back years and years and years, and is getting more difficult as palliative care services get equally pressured, don't they? Have you found that as well?
Absolutely. And what you'll find sometimes with lung cancer patients, they don't actually, even though they need that emotional, psychological symptom control support, it won't be deemed complex enough for referral to specialist palliative care. So the lung CNSs are holding on to these patients a lot longer than they probably would do before referring on. And right up to end of life. They might not actually be referred over to specialist palliative care at all. It might be a conversation with the district nurses and the GPs. So, we're having to expand the role even further to encompass that.
Back onto our positive spin, we don't want to be too negative. There are huge opportunities now in oncology clinics, in fact, thoracic oncology clinics, all the way from nurse-led treatment clinics, follow-up clinics. Tell us a little bit about the roles that you've come across people doing and the kind of benefits you perceive. I'm a huge supporter of this, and I'd be interested to hear your views.
Well, I am, because I do nurse-led clinics. I think they are great for the patient. We get really good feedback. So we have nurses across the UK doing immunotherapy clinics, TKI clinics, palliative care clinics, post-surgical and post-radiotherapy clinics, which is great because it gives the patient the time to discuss other things than just treatments, and also allows our colleagues like yourself to get on with the really complex patients that you need to see in clinic. So it's a win-win, really.
And if there's someone listening to this and they are hugely inspired by this, as of course they will be, and they're thinking, I want to do a follow-up clinic. And in fact, specialist nurse Michelle I work with at the West Middlesex is very interested in doing this. And if, like me, you're a complete idiot, you don't quite know the next step to take and how to do this, where do our colleagues make that next step if they want to develop, for example, a nurse-led TKI clinic or follow-up clinic or whatever it might be?
So obviously you have to have backing of your trust. You know, any clinic
Yes.
needs to be paid for, you know, so you need backing of your trust. You need to probably build a business case together for it. But I would say start small, work up, you know, get a niche of patients that you can actually look after. But most importantly, the nurse that's going to do it has to have the academic and experience behind them, and they have to be supported to be able to do that.
Yes. So I've done a little bit of this with pharmacists, and I have been a supervisor for my pharmacy colleagues becoming independent prescribing pharmacists, and they run their clinics. Is it presumably a similar kind of thing? You find your call.
Absolutely. I mean,
you find someone willing to help you.
Yes, absolutely. I mean, if you were doing a nurse-led clinic, you would expect to have at least clinical exam diagnostics at master's level, and also preferably non-medical prescribing, although you can get round a nurse-led clinic without prescribing, but it's beneficial if you can do it.
So we say we champion this completely, but make sure you have your qualifications, make sure you're backed by your trust.
Absolutely.
I've always thought about is try, and hopefully people have a suitable electronic patient record for nurses to document all the inputs they do, because I think so much goes unseen and the trust often doesn't see the value, sadly, the financial value in a specialist nurse. So every time you see someone, write it down or have a clinic or something.
Absolutely. And the benefits of having seen an actual formal clinic, the trust can see what's, you know, the benefit of that patient going into that clinic. Then it will reduce waiting times as well, because they won't be pushed into a general respiratory clinic.
Fantastic. Last question. So let's say that we have people listening who are saying, this is great. I'm really enjoying my work, but it's very difficult for me to, I haven't got time to do additional training. I find it difficult to access education, professional development. What avenues are there for people to seek additional training, courses, whatever it might be?
It's a difficult one, isn't it? Because yes, I get the fact that we're far too busy, and but we need to develop. And I think that's why you need the support of your colleagues and the consultants and the trust to say, well, I need this time out, I need to be able to do this. And then that will benefit the patients and it will benefit the trust. I think it's putting your case forward of how you're going to benefit A, patient, B, the trust. And this is what I need to do. And
does Lung Cancer Nurses UK, do you, excuse my ignorance, you run annual meetings? Do you run online courses as well?
So we have workshops on, we have on the website, we've got webinars on how to do business cases, nurse-led follow-up. We also have our national conference as well. We stay away from BTOG, so hopefully they can, they can attend both. But yes, if anyone's interested, just get in touch.
Fantastic.
Help further.
And to re-echo that about BTOG, we're very proud of our CNS members, one of our largest members groups, and we would of course always encourage people to come along to any of the BTOG educational events. Karen, that takes us to the end of our allocated 20 minutes. Thank you so much for sparing your evening to talk to me. So thank you, Clayton, for joining me. Thank you to our audience for listening. We hope that gave you some insight into lung cancer nursing specialism. For more information on BTOG, including education events, and of course, how to join, which we both recommend you do, you can visit www.btog.org. Thank you for listening.
Thank you.